Okay. Hello. Assalamu alaikum warahmatullahi wabarakatuh. Today's discussion is on lipid disorders. Lipid disorders are hyperlipidemia and presenting problems in lipid metabolism. The hyperlipidemia can occur in association with various diseases and drugs. Over or subclinical hypothyroidism may cause hypercholesteremia, and so measurement of thyroid function is warranted in most cases, even in the absence of typical symptoms and signs. Once secondary causes are excluded, primary lipid abnormalities may be diagnosed. Primary lipid abnormalities can be classified according to the predominant lipid problems: hypercholesterolemia, hypertriglyceridemia, or mixed hyperlipidemia. Although the single gene disorders are encountered in all the three categories, most cases are due to multiple gene polygenic interacting with environmental factors. Clinical consequences of dyslipidemia vary somewhat between these causes. These are the secondary causes of hyperlipidemia. Secondary hypercholesterolemia, moderately common in drugs such as diuretics, cyclosporin, glucocorticoids, androgens, and antiretroviral agents, hypothyroidism, pregnancy, and ischemic liver disease. Less common are nephrotic syndrome, anorexia nervosa, porphyria, and hyperparathyroidism. The secondary hypertriglyceridemia is due to the most commonly type 2 diabetes, chronic renal disease, abdominal obesity, excess alcohol, hepatocellular disease, and drugs, beta blockers, retinoids, glucocorticoids, antiretroviral agents. These are the causes of secondary hypercholesterolemia and secondary hypertriglyceridemia. Once again, secondary hypercholesterolemia causes are moderately common drugs, diuretics, cyclosporin, glucocorticoids, androgens, antiretroviral agents, hypothyroidism, pregnancy, cholestatic liver disease. Less common are nephrotic syndrome, anorexia nervosa, porphyria, hyperparathyroidism. Less common secondary hypertriglyceridemia. Common causes are type 2 diabetes mellitus, chronic renal disease, abdominal obesity, excess alcohol, high hepatocellular disease, drugs such as beta blockers, retinoids, glucocorticoids, antiretroviral drugs. Now we go to the first hypercholesterolemia. Hypercholesterolemia is a polygenic disorder, multifactorial genetic disorder that is most common cause of a mild to moderate increase in triglycerides, LDL cholesterol, mild to moderate increase in LDL cholesterol. Physical signs such as corneal arcus and xanthelasma may be found in this, as well as other forms of lipid disturbance. The risk of cardiovascular disease is proportional to the degree of LDL cholesterol or ApoB protein elevation, but is modified by other major risk factors, including HDL cholesterol and high lipoprotein A. So once again, hypercholesterolemia. Hypercholesterolemia is a polygenic disorder that is the most common cause of mild to moderate increase in LDL cholesterol. Physical signs such as corneal arcus and xanthelasma may be, these are present around the eyelids, on medial side of the eyelids, and the arcus analysis of corneal arcus is present on the corneal margins. This is lipid deposition in those areas. The risk of cardiovascular disease is proportional to the degree of LDL cholesterol or ApoB level. These are the apoproteins which uh, are involved in the, which acts as a cofactors for the metabolism of uh, lipoproteins or these lipids, but is modified by other major risk factors including low HDL cholesterol and high lipoprotein A. Familial hypercholesterolemia is more severe disorder with prevalence of at least 0.4% in most populations. It is usually caused by loss of function of mutation affecting the LDLR gene, which results in autosomal dominant pattern of inheritance. A similar syndrome can arise with loss of function mutation in the ligand binding domain of ApoB100 or a gain function mutation in PCSK9, which promote LDLR degradation. Causative mutation can be detected in one of these three genes by genetic testing in about 70% of patients with familial hyperlipidemia. Most patients with these types of familial hyperlipidemia have LDL cholesterol levels that are approximately twice as high as normal subjects of the same age and gender. Affected patients suffer from severe hypercholesterolemia and premature cardiovascular disease. Affected patients suffer from severe hypercholesterolemia and premature cardiovascular disease. Familial, familial hyperlipidemia may be accompanied by xanthomas of the Achilles and extensor tendons. These are the tuberous swellings of cholesterol on the Achilles and extensor deltoidal tendon, which are strongly suggestive of familial hypercholesterolemia. The onset of corneal arthritis before the age of 40 is also suggestive of this condition. Identification of the index case of familial hypercholesterolemia. The first case of familial hypercholesterolemia in a family should trigger genetic and biochemical screening of that family uh, members, which is cost-effective method case of detection. Affected individual should be managed from the childhood. Homozygous familial hypercholesterolemia may occur sporadically, especially in population in which there are the founder gene effect and consanguineous marriages. Homozygosity results in more extensive xanthomas and precocious cardiovascular disease. Early disease and extensive xanthomas and early cardiovascular disease, often in childhood. Hyper alpha proteinemia, hyper alpha lipoproteinemia refers to increased level of HDL cholesterol in the absence of increased LDL cholesterol. This condition rarely causes cardiovascular disease, but exceptions can occur, so it should not be regarded as a universally benign condition. Familial combined hyperlipidemia and beta lipoproteinemia may present with pattern of predominant hypercholesterolemia. Hypertriglyceridemia. Hypertriglycemia also usually involves polygenic factors, and both other common causes include excess alcohol intake, medications such as beta blockers and retinoids, type 2 diabetes, impaired glucose tolerance, central obesity, or other manifestations of insulin resistance, and impaired absorption of bile acids. It is often accompanied by postprandial hyperlipidemia and reduced HDL cholesterol, both of which may contribute to cardiovascular risk. It is often accompanied by postprandial hyperlipidemia and reduced HDL cholesterol, both which may contribute to cardiovascular disease. Excessive intake of alcohol or dietary intake and other exacerbating factors may precipitate a massive increase in triglyceride levels, which, if they exceed 10 millimole, 80 milligram per deciliter, may pose a risk of acute pancreatitis. If triglycerides are high, it is a predisposing factor for acute pancreatitis. Monogenic forms of hypertriglyceridemia occurs due to loss of function of mutations in the genes encoding lipoprotein lipase. If there is a deficiency of lipoprotein lipase, APOC2, or angiogenesis PTL4, which coordinates the lipolytic breakdown of triglyceride rich lipoproteins. These are the enzymes which are involved, and apoproteins which help in the lipolysis of the triglyceride rich lipoproteins. That is, chylomicrons are very low density lipoproteins. These cause recessively inherited forms of severe hypertriglyceridemia that is not readily amenable to drug treatment. They can present in childhood and may be associated with episodes of acute abdominal pain and pancreatitis. In common with other causes of severe hypertriglyceridemia, hepatomegaly, lipemia retinalis, in which the retinal arteries are lipemic, that means they look white and are eruptive xanthomas may occur. Familial hypertriglyceridemia may also be inherited in a dominant manner due to mutation in the ApoA5 gene, which encodes ApoA5, a cofactor that is essential for lipoprotein lipase activity. These disorders may also be associated with increased risk of cardiovascular disease. Familial combined hyperlipidemia and this beta lipoproteinemia may also present with pattern dominant of hypertriglyceridemia. Mixed hyperlipidemia, it is difficult to define quantitatively the distinction between the predominant hyperlipidemia and mixed hyperlipidemia. Predominant hyperlipidemia and mixed hyperlipidemia. The term mixed usually implies the presence of hypertriglyceridemia as well as increase in LDL cholesterol or intermediate density lipoproteins. Treatment of massive hypertriglyceridemia may improve triglyceride faster than the cholesterol, thus temporarily mimicking mixed hyperlipidemia. Primary mixed hyperlipidemia is usually polygenic and like predominant hypertriglyceridemia often occur in association with type 2 diabetes, impaired glucose tolerance, and central obesity, and other manifestations of insulin resistance. Both components of mixed hyperlipidemia may contribute to the risk of cardiovascular disease. Familial combined hyperlipidemia. Familial combined hyperlipidemia is a term used to identify an inherited tendency towards the overproduction of atherogenic apoprotein B containing lipoprotein. Familial combined hyperlipidemia is a term used to identify an inherited tendency towards the overproduction of atherogenic ApoB containing lipoproteins. It results in elevation of cholesterol, triglyceride, or both in different family members in different times. It is associated with an increased risk of cardiovascular disease, but it does not produce any pathognomonic clinical sign. In practice, this is relatively common condition is substantially modified by factors such as age and weight. Weight reduction can help. It may not be monogenic condition, but rather one end of the may be polygenic. This beta lipoproteinemia, this beta lipoproteinemia, also called type 3 hyperlipidemia, broad beta like dyslipidemia, a remnant hyperlipidemia, remnant chylomicron, a remnant LDL, VLDL cholesterol, involves the accumulation of roughly equimolar levels of cholesterol and triglycerides. It is caused by homozygous inheritance of a ApoE2 allele, which is isoform least avidly recognized by the LDLR. This apoprotein is not recognized by LDLR. So if there is deficiency of this gene, this apoprotein, then the LDR level will be high. The conjunction, then their lipid levels will be high. In conjunction with other exacerbating factors such as obesity or diabetes, it leads to accumulation of atherogenic intermediate density lipoprotein and chylomicron remnants. Premature cardiovascular disease is common as in peripheral vascular disease. It may also result in the formation of Palmer xanthomas, tuberous xanthomas, or tendon xanthomas. Next, the rare dyslipidemias. Several rare disturbances of lipid metabolism have been described. They provide important insight into the lipid metabolism and its effect on risk of cardiovascular. Fish eye disease are ApoA1, apolipoprotein A1 deficiency, and lecithin cholesterol acyltransferase deficiency demonstrate low very low HDL cholesterol levels do not necessarily cause cardiovascular disease, but ApoA1 deficiency and possibly Tangier's disease demonstrate that low HDL cholesterol can be atherogenic under some circumstances. Tangier's disease and ApoA1 deficiency can cause cardiovascular disease. Autosomal recessive familial hypercholesterolemia and PCSK9 protease convertase substituting Kexin 9 gain of this is a protein gain of function of the mutation revealed to importance of proteins that chaperone the LDL receptor. Cytosporolemia and cerebrotendinous xanthomatosis demonstrate that sterols other than cholesterol can cause xanthomas and cardiovascular disease. While PCSK9 loss of function mutation, A beta lipoproteinemia, these are the causes of PCSK loss of function mutation, A beta lipoproteinemia, and hypo-beta lipoproteinemia suggest that low levels of apo beta containing lipoprotein reduce the risk of cardiovascular disease. The only adverse health outcomes associated with extremely low plasma lipid levels in the later two conditions is attributable to fat soluble vitamin D deficiency and impaired transport of lipid from the intestine and liver. Principle of management. Lipid-lowering therapies have the key role in the secondary and primary prevention of cardiovascular disease. Assessment of absolute risk of cardiovascular disease, treatment of all modifiable risk factors, and optimization of lifestyle, especially diet and exercise, are central to the management of in all cases. In all these cases, the management of diet and exercise are important. Patients with a greatest absolute risk of cardiovascular disease derive the greatest absolute benefit from treatment. Public health questionnaire organizations recommend threshold for the introduction of lipid-lowering therapy based on the identification of patients in very high-risk categories or those calculated to be at high absolute risk according to the algorithms or tables such as Joint Societies of Coronary Risk Prediction. These tables, which are based on large epidemiological studies, should be recalibrated for the local population. If possible, in general, patients who have cardiovascular disease, diabetes mellitus, chronic renal impairment, familial hypercholesterolemia are an absolute risk of cardiovascular disease of more than 20% in the ensuing 10 years are arbitrarily regarded as having sufficient risk to justify drug treatment. Age is such an overwhelming determinant of absolute cardiovascular risk that some recent recommendations consider lifetime risk. This diminished the pressure to treat very elderly patients and support earlier intervention in non-elderly patients. In non-elderly patients with hypercholesterolemia or hypertriglyceridemia, they should be treated early, and in elderly patients, treatment can be, if there are harmful effects, treatment can be abandoned. Public health organization also recommend wide target levels of for patients receiving drug treatment. High risk patients should aim for HDL cholesterol greater than 1 millimole or 38 milligram per deciliter and fasting triglyceride less than 2 millimole per liter or approximately 180 milligram per deciliter. While target levels for LDL cholesterol have been reduced, that is 1.8 millimole or 76 milligram per deciliter or less. In general, total cholesterol should be less than 5 millimole or less than 190 milligram per deciliter during treatment and less than 4 millimole or approximately 150 milligram per deciliter in high-risk patients and in secondary prevention of cardiovascular. Recent trials have demonstrated continuous benefit of low-density lipoprotein cholesterol reduction to a level of 1.4 millimole per liter or 54 milligram per deciliter. So further reduction in treatment targets may be anticipated. Non-pharmacological treatment of hyperlipidemia includes patients with lipid abnormalities should receive medical advice if necessary, dietary counseling, reduce intake of saturated fats to 7 to 10% of total energy intake, reduce intake of cholesterol less than 25 milligrams per day, replace sources of saturated fat and cholesterol with alternative foods such as lean meat and low fat dairy products and polyunsaturated fats and low glycemic index carbohydrates. Reduce energy dense foods such as fats and drinks while increasing activity and exercise to maintain or lose weight. Increased consumption of cardioprotective and nutrient-dense foods such as vegetables and unrefined carbohydrates, fish, pulses, and nuts and legumes and fruits. Adjust alcohol consumption, reducing intake if excessive or if associated with hypertension, and hypertriglyceridemia or central obesity. This should be avoided. Achieve additional benefits with preferential intake of foods containing lipid-lowering nutrients such as N3 fatty acids, dietary fiber, and plant sterols. Pharmacological, the response to diet is usually apparent within 3 to 4 weeks, but dietary adjustment may need to be introduced gradually, although hyperlipidemia in general and hypertriglyceridemia in particular can be very responsive to these measures. LDL cholesterol reduction are often only modest in routine clinical practice. Explanation, encouragement, and persistence are often required to assist patient adherence. Even minor weight loss can substantially reduce cardiovascular risk, especially in central obesity patients. All other modifiable cardiovascular risk factors should be assessed and treated. If possible, intercurrent drug treatments and that adversely affect the lipid profile should be replaced. Pharmacological management in case of the main diagnostic categories provide useful framework for management of the selection of first-line pharmacological treatment. Hypercholesterolemia can be treated with one or more of the cholesterol-lowering drugs. Statins, these reduce cholesterol synthesis by inhibiting HMG-CoA reductase enzyme, which is involved in the synthesis of cholesterol. The reduction in cholesterol synthesis upregulates the production of the LDLR, LDL receptor, which increases clearance of LDL and the precursor intermediate density lipoprotein, resulting in secondary reduction in LDL synthesis. Statins reduce LDL cholesterol by 60%, reduce triglyceride by 40%, and increase HDL cholesterol by 10%. They also reduce the concentration of intermediate metabolites such as isoprenes, which may lead to other effects such as suppression of inflammatory response. There is clear evidence of protection against total and coronary mortality, stroke, and cardiovascular events across the spectrum of cardiovascular disease. Statins are generally well tolerated and serious side effects are rare, below 2%. Liver function test abnormalities occurs and muscle problems such as myalgia asymptomatic, increase in creatine kinase and creatine kinase myositis, and infrequently rhabdomyolysis are the most common side effects, are more likely in patients who are elderly, debilitated, and receiving other drugs that interfere with the statin degradation, which usually involves cytochrome P450 3A4 glucuronidation. So the next is these are the statins. Next is the ezetimibe. This ezetimibe inhibits the activity of the intestinal mucosal transporter and Niemann-Pick C1L1 receptor, which is responsible for absorption of dietary and blood cholesterol. The resulting depletion of hepatic cholesterol upregulates the hepatic LDL receptor production. This mechanism of action is synergetic with the effects of statins. Monotherapy in a 10 milligram a day dose reduces LDL cholesterol by 15 to 20%, slightly greater, 17 to 25 incremental LDL cholesterol reduction occurs when ezetimibe is added to statins. Ezetimibe is well tolerated and evidence of beneficial effect on cardiovascular disease endpoint is now available. Plant sterols food, supplemented foods which also reduce cholesterol absorption and lower LDL cholesterol by 7 to 15%. Bile acid sequestering raisins drugs in this class includes cholestyramine, cholesterol, and Polcivilam. These prevent the reabsorption of bile acids, thereby increasing de novo bile acid synthesis from hepatic cholesterol. As with ezetimibe, the resultant depletion of hepatic cholesterol upregulates the LDL receptors activity and reduces LDL cholesterol in a manner that is synergistic with the action of statin. Raisins reduce LDL cholesterol and modestly increase HDL cholesterol, but may increase triglycerides. They are safe but may interfere with the bioavailability of other drugs. Polcivilam has fewer gastrointestinal effects and than older cholestyramine and cholesterol drugs. The depletion of bile acids is sensed via the depletion of bile acids is sensed via the farnesyl X receptor, and the response may also improve glucose metabolism. PCSK9 inhibitors, monoclonal antibodies, have been developed that neutralize the PCSK9, an enzyme that degrades the LDL receptor. PCSK9 is an enzyme that degrades LDL receptor. This causes levels of LDL receptor to increase, which markedly reduces LDL cholesterol, As the LDL receptor increases, which markedly reduces the LDL cholesterol from the blood. The PCSK9 inhibitors currently available are evolocumab and elirupumab. These are very costly drugs which are administered by subcutaneous injection every 2 to 4 weeks. These drugs are well tolerated and highly effective. Reduction in LDL cholesterol of about 50 to 60% have been observed in patients who have not responded adequately to the standard lipid-lowering therapy, and this has been accompanied by a reduction in the risk of cardiovascular events by about 15%. The PCSK9 inhibitors do not deplete intracellular concentration, and because of that, do not trigger compensatory mechanism that blunt the effect of other cholesterol lowering medications. Nicotinic acid can also be pharmacological. Doses reduce peripheral Pharmacological doses reduce peripheral fatty acid release, with the result that the very low density lipoprotein and LDL decline, and while HDL cholesterol increases. Recent randomized controlled trials have been disappointing regarding effects of atherosclerosis and cardiovascular events. The same may be said of novel agents that inhibit cholesterol ester transfer protein. Cholesterol ester transfer proteins. Neither of these HDL cholesterol raising drug is indicated in current lipid metabolism. Combination therapy in many patients, treatment of predominant hypercholesterolemia can be achieved by diet plus the use of diet, exercise plus the use of statin in a sufficient doses to achieve target LDL cholesterol level. Patients who do not reach LDL targets on the highest tolerated statin dose or who are intolerant to statins may receive ezetimibe. Plant sterols, plant sterols are resins. Ezetimibe and resins are safe and effective in combination with statin because the mechanism of action of individual therapies is complementary to each other. Is complementary to each other. Hypertriglyceridemia, predominant hypertriglyceridemia, predominant hypertriglyceridemia can be treated with one of the triglyceride lowering drugs. These are the fibrates. These stimulate the peroxisome proliferator activated receptor alpha, which controls the expression of gene products that mediate the metabolism of triglycerides and HDL. These control the expression of gene products that mediate the metabolism of triglycerides and HDL. As a result, synthesis of fatty acids and triglycerides and VLDL is reduced, while that of lipoproteins lipase, which catabolizes the triglyceride, is enhanced. In addition, production of ApoA1 and ABC1, this is adenosine triphosphate binding acid A1 is upregulated, leading to increased reverse cholesterol transport via HDL cholesterol, via HDL. Consequently, fibrates reduce triglyceride by up to 50% and increase HDL cholesterol by up to 20%, but LDL cholesterol changes are variable. Few large scale trials have been con conducted with fibrates than with statins. The results are less conclusive, but reduced rates of cardiovascular disease have been reported with fibrate therapy in the subgroup of patients with low HDL cholesterol and elevated triglycerides. Fibrates are usually well tolerated but share similar side effect profile to statin. In addition, they may increase the risk of polylithysin and prolonged action of anticoagulants. Accumulating, the evidence suggests that they may also have a protective effect against diabetic microvascular complications. High polyunsaturated long-chain fatty acids. These include eicosapentaenoic acids and docosahexaenoic acids, which comprise approximately 30% of the fatty acids in fish oil. 30% of the fatty acids in fish oil. EPA and DHA are the potent inhibitors of VLDL triglyceride formation. Intakes of more than 2 grams of N3 fatty acids, equivalent to 6 grams of most forms of the fish oil per day, lower triglycerides in a dose-dependent fashion. Up to 50% reduction in triglycerides may be achieved with 50 grams of fish oil per day. Changes in HDL cholesterol are variable, but fish oils do not routinely reduce LDL cholesterol. Fish oil fatty acids have also been shown to inhibit platelet aggregation and improve cardiac arrhythmias in animal models. Dietary and pharmacological trials suggested that N3 fatty acids may reduce mortality from coronary heart disease. but the benefit of fish oil supplement has been less conclusive in recent trials. Fish oils appear to be safe and well tolerated, but dietary fish consumption is the preferred source. Patients with predominant hypertriglyceridemia who do not respond to lifestyle intervention can be treated with fibrates or fish oil depending on the individual response and tolerance. If target levels are not achieved, the fibrates, fish oil, and possibly nicotinic acid can be combined. Massive hypertriglyceridemia may require more aggressive limitation of dietary fat intake, less than 10 to 20% of energy as a fat. Any degree of insulin deficiency should be corrected insulin because insulin uh, is required for optimal activity of lipoprotein lipase. The initial target of patients with massive hypertriglyceridemia is the triglyceride less than 10 millimole or 880 milligram per deciliter to reduce the risk of pancreatitis. Mixed Mixed hyperlipidemia can be difficult to treat. First-line therapy with statins alone is unlikely to achieve the target level once fasting triglycerides exceed approximately 350 milligram. Fibrates are the first line of therapy of the for this beta lipoproteinemia, but may not control the cholesterol component in the form of mixed hyperlipidemia. Combination therapies often required. Effective combination includes statin plus fenofibrate, recognizing that the risk of myopathy is increased with gemfibrozole, but fenofibrate is relatively safe in this regard. Statin plus fish oil when triglyceride is not high. Fibrate plus acetamide when cholesterol is too high. When cholesterol is not high. Statin plus fibrinate, recognizing that the risk of myopathy is increased with gemfibrozole and fenofibrate is relatively safe in this regard. Statin plus fish when triglyceride is not too high. Fibrates plus acetamide when cholesterol is not too high and triglycerides. Monitoring therapy, monitoring of therapy, the effects of lipid lowering therapy should be assessed after 6 weeks or 12 weeks for fibrates. At this point, it is prudent to review the side effects, lipid response, CK level, creatinine kinase, and liver function tests. During longer term follow-up, adherence to treatment, diet and exercise should be assessed with monitoring of weight, blood pressure, and lipid levels. So the monitoring of the during long-term follow-up, adherence to treatment, diet and exercise should be assessed with monitoring of weight, blood pressure, and lipid levels. The presence of cardiovascular symptoms or signs should be noted, and absolute absolute cardiovascular risk assessed periodically. Effective statin therapy may be associated with paradoxical and even unexplained increase in coronary calcium score. It is not necessary. It is not necessary to perform routine check of creatine kinase and liver function unless symptoms occur. If statins are in combination with fibrates or other drugs that may interfere with their clearance. If myalgia or weakness occurs, if myalgia weakness occurs in association with CK elevation, over 5 to 10 times the upper limit of normal, or if sustained alanine aminotransferase elevation occurs, then 2 to 3 times of the upper limit of normal normal occurs that is not accounted for by fatty liver, treatment should be discontinued and alternative therapy sought. The principle of management of dyslipidemia we will discuss. Once again, we go back to the this is the picture of lipid metabolism, dietary triglycerides, cholesterol, dietary triglycerides, cholesterol, these go into the intestine and intestine, small intestine. Chylomicrons are formed, triglyceride, cholesterol, ester, lymph, it goes into the lymph, lymphatics and lymphatics with chylomicron, triglyceride, ester. This is the lipoprotein lipase. It removes fatty acids, which is utilized by peripheral tissue, triglycerides, cholesterol. This is all the mechanism, PCSK, degrading the LDL receptors. So these are the mechanisms. Due to shortage of the time, I was unable to touch these things. This is the molecule of this is molecule called lipoprotein. This is a lipoprotein molecule which contains apolipoprotein, free cholesterol, phospholipid, triglyceride, cholesterol esters. And then we go to the conditions which we were discussing. These are the classification of hyperlipidemia, predominantly hypercholesterolemia, polygenic familial hypercholesterolemia due to the LDL receptor defect, or apolipoprotein B100 defect, are due to the increased function of PCSK9 and hyper alpha lipoproteinemia. In these conditions, there is elevated total cholesterol, triglyceride, total cholesterol is elevated, plus minus triglycerides. The elevated lipoproteins are LDL, HDL in this case, LDL plus minus VLDL. In this case, there is familial hypercholesterolemia, there is coronary heart disease risk is very high, and this is less. Predominantly hypertriglyceridemia, polygenic etiology is polygenic, and lipoprotein lipase deficiency, familial hypertriglyceridemia. Triglycerides are increased, and in certain cases, total cholesterol is also raised. So, in this condition, there is pancreatitis is more common, and there is also risk of questionable risk of coronary artery disease. Mixed hyperlipidemia, polygenic and familial combined hyperlipidemia and dysbeta-lipoproteinemia. In this case, total cholesterol plus triglycerides are raised. VLDL, LDL, these are the lipoproteins, LDL raised, and in this case, there is increased intermediate density lipoprotein, there is increased risk of coronary artery disease and less likely pancreatitis. So now we go to the statin treatments may be required from the age of about 10 years in cases of familial hypercholesterolemia. In adolescents, statin treatment may be required from the age of about 10. It does not compromise normal growth and maturation. Smoking patients should be strongly advised not to smoke. Adherence to medication critically important. Success of treatments. Simple regimen should be used, and education and support provided. Now we come to the principles of management. Principle of management are: first is the diet, exercise, exercise, and low fat diets, exercise. These are some dyslipidemias. Now we discuss. Reduced intake of saturated fats, 7 to 10% of total energy. Reduced intake of cholesterol, less than 250 milligram per day. Replace sources of saturated fat and cholesterol with alternative foods such as lean meat and low-fat dairy and products and polyunsaturated fats and low glycemic index carbohydrates. Reduce energy dense foods such as fats and soft drinks, and increasing activity and exercise to maintain lose weight. Increase consumption of protective and nutrient food dense food such as vegetables and unrefined carbohydrates, fish, pulses, nuts, legumes, and fruits. Adjust alcohol and achieve additional benefits with polyunsaturated such as fish oils or fish. So these are the algorithm showing the predominant hypercholesterolemia management. First line treatment is with statin. Statin prevents the HMG-CoA enzyme in reductase and causes the reduction in the cholesterol level. First line treatment with statin, ezetimibe, if intolerant, cholesterol, ezetimibe inhibits the uh, intestinal uh, Niemann-Pick C1L1 transporter, and so it causes also reduces the cholesterol level. The monitor lipids and monitor other side effects such as liver and muscle injury by the statins. Titrate the dose. Statin plus minus ezetimibe, resins such as nicotinate, and if resistant, then PCKS, PC, ECSK9 inhibitors. Mixed hyperlipidemia combination treatment if triglycerides and LDL cholesterol are more than 4 millimole per liter, statin plus fish oil, fibrate, ezetimibe, statin plus nicotinate, statin plus fibrate, monitor the side effects. The predominant hypertriglyceridemia, the first line treatment is with fibrate and fish oil if intolerant. Monitor lipids. First line treatment is with fibrate and fish oil if intolerant. Monitor lipids and monitor for side effects. Titrate fish oil and fibrate plus minus fish oil plus minus nicotinate, and if resistant PCSK9 inhibitors may be used. Management of hyperlipidemia in old age, prevalence of atherosclerosis, cardiovascular disease, greatest in old age, associated cardiovascular risk, lipid levels become less predictive as do other factors apart from age itself. Benefit of statin therapy maintained up to the age of 80 years, but evidence is lacking beyond this. Life expectancy and statin therapy, lives saved by intervention are associated with shorter life expectancy than younger patients. And so the impact of statin on quality adjusted life here is similar in old age. Life expectancy and statin therapy, lives saved by intervention are associated with shorter life expectancy than in younger patients. And so the impact of statins on quality adjusted life appears smaller in old age. Then this lipidemia in pregnancy, lipid metabolism, lipid and lipoprotein levels increase during pregnancy. This includes an increase in low-density lipoprotein cholesterol, which resolves postpartum. Remnant dyslipidemia and hypertriglyceridemia may be exacerbated during pregnancy. Treatment dyslipidemia is rarely thought to warrant urgent treatment, so pharmacological therapy is usually contraindicated when conception and pregnancy is anticipated. Teratogenicity has been reported with systemically absorbed agents, and non-absorbed agents may interfere with nutrient bioavailability monitoring. While still uncommon among women of childbearing age, cardiovascular disease is increasing in prevalence. Pre-conception cardiovascular review should be considered for women at high risk to optimize medication for pregnancy and to ensure the patient will be able to withstand the demands of the pregnancy and labor. This was these are the dyslipidemias, such as Tangier disease, in which there is very low HDL and low total cholesterol, and in which cardiovascular risk is mild. Apolipoprotein A deficiency, very low HDL, chances of cardiovascular risk is high. APO, apolipoprotein A1 melanoma, very low HDL. Fish eye disease, very low HDL and high triglycerides. Lecithin cholesterol acyltransferase deficiency, very low HDL, high triglycerides. Autosomal recessive familial hypercholesterolemia, very high LDL and cardiovascular risk is very high. Cetosterolemia, high plant sterols, including cetosterol, mild risk of cerebrotendinous and xanthomatosis, bile acid defect is bile acid defect, cholesterol accumulation, and there is chances of mild cardiovascular disease. Thank you very much. If you have time,